Welcome, everyone. Thank you for joining today's webinar. So before we get started, just wanted to mention, if you have any technical issues during the course of the webinar, you could chat in to the host in your chat box. And at the end of today's webinar, please complete our brief survey to give us some ideas about additional topics you would like us to cover. During the webinar, you can chat in comments or questions to the panelists. We're going to be compiling those and holding those until the Q&A part of our presentation today. And thanks again for joining us. Let's get started. So on behalf of the Community Technical Assistance Center of New York, it's my pleasure to welcome you to the Mental Health Moment. It's an opportunity for us to discuss some of the more salient and timely issues in children's mental health. And in today's Mental Health Moment, we're going to be discussing the current crisis in children and child and adolescent mental health. My name is Jim Rodriguez, and I'm the Director of Trauma-Informed Services at the CTAC, and I'll be moderating the webinar today. And I'm joined today by Doctors Timothy Rice and Aaron Reliford. Dr. Rice is a board-certified child and adolescent psychiatrist and psychoanalyst. He serves as the chief of the Mount Sinai Health System's Child and Adolescent Inpatient Psychiatry Service. And Dr. Aaron Reliford is an associate clinical professor of child and adolescent psychiatry at the Child and Adolescent, a Child and Adolescent Psychiatry Fellow Training Director at NYU, and both the Director of Child and Adolescent Psychiatry and the Associate and Interim Medical Director of Behavioral Health Sunset Terrace Family Health Center of NYU Langone in Brooklyn. Before we start our conversation, just want to sort of find out who's here, just to get a sense of who's in our audience. So if you could just quickly chat in some of your information, your name, what agency you work for, and where you're located. Please feel free to chat that information in, and we're going to get started. As we move into the conversation, though, we're very fortunate to have Doctors Reliford and Rice. Dr. Rice represents inpatient psychiatry, and Dr. Reliford works in primarily in outpatient services. So we're going to get both perspectives on this. And so I see there's a lot of folks here. Thank you, everyone. PAs. Welcome, everyone. I'm going to jump right in and just present a little overview of the problem and where we stand right now in child and adolescent mental health. So first, we know that there's a lot of challenges that young people are facing today between the health crisis and many other stressors going on in the larger society. We know that young people are faced with increasing challenges. And the Surgeon General's advisory has emphasized that COVID-19 may have exacerbated pre-existing conditions, and there's alarming rates of mental health issues among our young people. And the nation's top mental health experts in pediatric health have declared a national emergency in child and adolescent mental health. We know that many of you are very much aware of this because you live it on a daily basis, but we do want to have an opportunity to discuss it. The Surgeon General, Dr. Vivek Murthy, has come out and made it clear the pandemic's era's unfathomable number of deaths, pervasive sense of fear, economic instability, and forced physical distancing from loved ones, friends, and communities have exacerbated the unprecedented stress young people already face. And in addition to that, as we've mentioned, as I was mentioning earlier, all of that is occurring on top of many other issues that young people may face. So we know that through this pandemic, they may be exposed to higher rates of those ACEs, adverse childhood experiences. There's a larger conversation in society, a racial reckoning, political turmoil, and environmental concerns. When I think about growing up as a young person during these times, I could only imagine it can seem like the world and society is falling apart. So these forces, regardless of how they're viewed, represent chronic stressors that can disrupt the lives of young people and the families in which they're growing. And then just a few statistics here. Depressive and anxiety symptoms have risen by 50% during the pandemic among young people. Negative emotions or behaviors as irritability and impulsivity have increased as well. We know that from 2000, or some of the data suggests from 2009 to 2019, high school students reporting persistent feelings of sadness or hopelessness has increased by 40%. The share of young people seriously considering or attempting suicide has increased by 36%, and the share of young people creating a suicide plan has increased by 44%. So not only do we see increases in suicide attempts, suicidality, but also in deaths occurring from suicide. In 2021, emergency room visits for suicide attempts were 51% higher for adolescent girls and 4% higher for adolescent boys compared to 2019. And so with that information as a backdrop, we're gonna start our conversation with Doctors Rice and Reliford. Again, as we mentioned, please feel free to chat in your comments or questions as we go along. So let's just jump right in. I want to start off with the problem. So, Tim, I'll start with you, and both of you can answer this question because I want to get your sense of what have you seen occurring. So as we think about the problem, when you go back to the beginning of the pandemic, and again, for everyone here, again, we're very lucky to have Doctors Rice and Reliford here because they've been involved in this crisis from the beginning. So I want to get your thoughts, though, on how have you seen things progress during the pandemic? How have you seen things sort of play out with young people and their mental health needs through this pandemic?
Yeah, let me begin by thanking you, Dr. Rodriguez, for having Dr. Reliford and I, and thank you to the CTAC, and thank you to the audience for being here today. I think this is going to be a really nice conversation, and it's really an honor. In terms of the progression, it's been very complex. I would say, and I personally remember when the pandemic really first affected New York City, I think it was March, April, when we had that first very big peak. And as an inpatient provider, how I mostly experienced it with children is how many children are being admitted to our inpatient services, and how easy is it for us to have children be able to step down to a lower level of care. And interestingly, in those very first weeks, we had a pretty sharp emptying of our units. It felt very eerily calm in that first little peak. And I think what was happening at that time was there was a real sense of urgency and physical needs of children, and parents were understandably wanting to make sure that children were safe. And there was a real focus on trying to get through the early stages of the pandemic by focusing on physical health. And what I recall very clearly right after that was the summer of that year. Ordinarily, the summer for us is sort of a time of relative calm. Usually schools are out of session as they were then. But with schools out, usually there's less referrals to emergency rooms and less admissions that are precipitated by that. And as a result, our census, we're a 17-bed unit. Ordinarily, during most of the year, we're full. We're about 17 out of 17. But in the summer months, often it's about maybe 10. That summer, we were full 17 out of 17. And I have seen it consistently since then be pretty much 17 out of 17 since. It's been extremely, very much so a need for mental health inpatient resources since that very opening stage of the pandemic. And I think too, what's been a very interesting trend is it hasn't been only from the city. On our inpatient unit, we admit from the emergency rooms in Manhattan and also in the boroughs, but we also take in cases from regional hospitals, sometimes as far up as the Catskills or from New Jersey or elsewhere in the region. And we've seen a need to increasingly try to, when we can, accommodate kids from pretty far away locations, and that the hospitals in those areas are also really overflowing with children. And when I look at sort of what might be creating some of those needs, I think kids do have real mental health needs that are precipitating it. But also, and this is where I'll maybe hand off to Aaron to see if sort of his experience matches this, but also to speak from his area of expertise in terms of outpatient care. We've seen our length of stay lengthen somewhat, primarily because we've had difficulties finding kids that have a lot of needs to match them with the right level of outpatient services, in the sense that ordinarily, if we find a kid who has a pretty substantial need for therapy, that you could disposition a kid to a clinic where they're going to be getting care once a week in psychotherapy with medication management, or you could disposition them to, say, an intensive outpatient program or a partial hospitalization program where the services are going to be significantly higher. We're no longer finding it's as an easy process to obtain access to that immediately. And sometimes children are waiting on an inpatient setting to be able to access those services, which then sort of backs up into the emergency rooms and can sometimes leave kids with 2, 3, if not 4 weeks of sort of sitting in an emergency room setting while waiting for an inpatient bed, which you can imagine is a terrible situation for a family and a child to be in. So I think in the coming months, it'll be very interesting to see how this all evolves. I'll hand it over to Dr. Reliford to sort of take this in any direction he may like.
Sure. No, thanks, Tim. Again, echoing what Dr. Rice mentioned. Thank you, CTAC, for putting this on. Thank you, Dr. Rodriguez, for facilitating this. I think much of what Dr. Rice just mentioned is exactly what I saw as well. While I certainly don't cover all aspects of outpatient care, I saw a lot in a lot of different sectors. So covering from Bellevue emergency room and inpatient settings to the Child Study Center at NYU, and also the outpatient services at NYU Brooklyn, and then the school-based mental health clinics that we also serve in Brooklyn. I got a chance to really see where things were, and absolutely at the beginning in March, you really didn't see as much volume in terms of emergency room care or inpatient settings. And I think what we started to see over the first couple months, starting in March, is that the severity of the symptoms of those who actually landed in the hospitals were actually much more acute. So the suicide attempts were much more severe. You had individuals with a higher level of really severe pathology. And as those months dragged on, we started to see that more and more, even before the volume actually dramatically increased. And what I think that was a reflection of was similar to what Dr. Rice mentioned, was certainly individuals sort of pulling back from in-person at school, in-person care in the school systems, in-person care, outpatient preventative care. But then it was sort of that pulling back from preventative and primary services prevented individuals from being able to address sort of more mild to moderate presentations, and that led to more severe presentations that actually came about. So that's the trajectory. And just like Dr. Rice mentioned, since then, it's been pretty much up in terms of the volume. Since that spring and summer of 2020, the volume in the emergency rooms has dramatically increased. And to echo what Dr. Rodriguez mentioned, you've certainly seen an increase in depression, anxiety, overdoses, suicide attempts, and all of those. So that maintains even to today. The emergency rooms are packed. The demand and waiting lists for services in all of our outpatient mental health settings has dramatically increased. And I think one of the benefits, which we'll talk about at some point, was that we were able to quickly shift over to a thorough telemedicine platform that helped to maintain access. But, there are some challenges there as well.
Thank you. And I did want to ask too, so I think some of the problems that you're describing, Aaron, I know you have the sort of, we talked about suicidality, substance abuse problems, overdoses. If you can give us a little bit more of a picture, so we know those, in addition to those, what are some of the other things that young people are presenting with? Or is that pretty much taking up, and because it sounds like there's in many ways, a bottlenecking with kids with the more severe needs, obviously coming forth, but that those other kids who have less severe needs. So I think you're describing this, but what are some of the problems that you're seeing as well? What are the areas and the difficulties that young people are coming in with?
Yeah.
If you could say a little bit more about that. Yeah.
Absolutely. So starting from in to out, but Tim definitely will be able to talk about more of what he's seen on the inpatient unit. The folks who were on the inpatient unit that I started to see earlier on were, as I mentioned, had more severe presentations. So depression with suicide attempts that were a lot more lethal. And you had individuals who were coming in with decompensated psychotic symptoms and psychotic presentations that were always there, of course, but it just was at a level of untreated severity that just was more, right? And just as you mentioned, I think also what we were seeing presenting to the clinics was mostly an increase in depression and anxiety, right? And reasonably so, right? There were people who were specifically stressed about uncertainty in the midst of the pandemic, and those who were already vulnerable were certainly presenting as more acute and having more challenges at that time. You were seeing sort of more self-injurious behavior and more overdoses as well, or suicide attempts of various means, but overdoses in the kids and the adolescents. So those are the things that we were primarily seeing. I know that the research has been showing that there was a much greater increase in the prevalence of substance use of folks of all ages, including adults. And certainly we saw some of that, but that was less of a proportion than the other sort of categories that I had mentioned before.
They follow up with one point on substance use. I remember very vividly in the first year of the pandemic, finding a much higher proportion of substance-induced psychosis amongst the adolescents in particular from the inpatient setting. And when I would ask about this often, it seems like part of the reason for that was the children or the adolescents weren't having the normal avenues by which they were accessing cannabis. With the schools being closed, that it seemed that they were going through other sort of avenues, and they were often getting access to things like synthetic cannabinoids with K2, or they were having supplies that were laced or tainted by sort of needing to get their substances through other areas. That then seemed to fall off. I haven't seen that as much recently, and I think that's with some of the back to school and in person being a more common thing, and also after I think just an immediate jarring sort of 2020 experience. But I do remember really vividly we had sometimes a quarter of our children and adolescents on the units were psychotic, and I think that speaks to what Dr. Reliford was saying. Psychosis is a very severe presentation, and we would often have one or two at any given time, but we had much higher rates, I found, of psychosis, and usually it was some substance impact.
For both of you, I'm curious to what degree, though, and it sort of, I'm very much into narrative work. And so what are the stories that you were hearing from kids behind that, in terms of the degree to which COVID-19 was precipitating this, or the loneliness or the withdrawal that we're seeing? Can you share a little bit about that? What were you hearing? And I'll start with you, Tim. Yeah, just a little bit about what's behind that, and what was behind that? Can you give us a sense of what young people were saying with regards to all of these problems, right? And it could be obviously different depending on the issue.
Yeah. You know, I mean, my first association was I remember an adolescent who was spending almost the entirety of his day at a mostly empty skate park with both of his parents stressed while working from home and really unable to give any time to him. And there was in that adolescence narrative just like a real profound sense of like not fitting in or not belonging anywhere, where sort of the home now felt a little bit more like not even his own place. That like when he would go to school or when parents were at work, it felt like if everyone were to come together and re-enter that space, then there would be a home. It's just that people weren't there, but with people now there but doing sort of, you know, their own work obligations, or in his sort of place, like, you know, essentially skipping school, it just felt like alien or other. And there was something very dark about that story that I remember with him that was very sad. But you know, it's one of my favorite things about inpatient work is you do hear, you know, thousands of stories. I mean, you get that in all of child and adolescent psychiatry, and they're so rich at different developmental ages and different ways of seeing the world based on, you know, the age and the life of the individual. I found it to be, you know, really compelling. I wonder, Dr. Reliford, if you have any narrative that stands out to you.
Yeah, I think, like you mentioned, it's varied, right? So I think there were several different kinds of presentations. You certainly had those who had, you know, more severely activated anxiety. And, you know, they presented with that. The parents brought them in and said, look, he's more anxious because he's worried about, or she's worried about things related to COVID, or worried about us getting COVID, or things along those lines. But then, you know, that was sort of relatively a smaller percentage. I think most people weren't sort of coming in saying that. I mean, you did have more people coming in saying that, but mostly it was what was dug up, right? So I think myself and most of our practitioners and most of you as well probably started asking about, well, what kind of COVID related stressors are happening in your lives, meaning for the children and the adolescents. And then you started to hear more and more, and you started hearing the stories of what was happening in the home. So one of the things, a couple narratives that were common for some of the families we were treating down in Sunset Park in Brooklyn was that the kids just stayed in the house, right? The parents were worried, reasonably so, and they were not at school. And it was on some level more convenient, but also safer to keep them in the house. And so they were in the house all day. And while they weren't in those moments expressing fear about the pandemic, it was really taking over their lives in a way that dictated what it is that they were able to do. And so I think that those are some of the other narratives. I mean, then you have the narratives in terms of the shifts, right? So I think there was a lot of apprehension and uncertainty created as the kids were going from Zoom back to school and back and forth. That was pretty disruptive. And then when you had like more of a firm shift from kids being away from school and then going back into school, you know, I had a couple kids that were like, no, I'm not worried about this at all. I think I'm perfectly fine. But then when they're in the room next to other children and next to other adolescents, they become anxious about what's actually happening, what their risks are in that moment. And then it sparks a whole new wave of anxiety. So I think it very much varies. And it's definitely behooves us to really inquire and ask about it, because the kids aren't necessarily going to come in and start talking about it.
Thank you. You know, throughout the pandemic, we've been hearing a lot about disparities, and disparities, obviously, in things like infection rates and mortality rates, and disparities by race, and gender, and the intersection of those as well. So I wanted to get your sense as well, in terms of how you see those disparities possibly playing out in the work that you're doing, and in the settings that you work. Are you seeing some of those disparities playing out with the work that you do? And I say that also not just, again, generally in infection rates and health and then mental health issues, but also disparities, as we know, in those kind of social determinants of health, right? Those added factors around education, poverty, and other issues that obviously can exacerbate difficulties. Can you say, and I'll start with you, Aaron, Dr. Reliford, if you can start us off. What are you seeing, or have you seen these kinds of disparities playing out in your work?
Yeah, no, absolutely. I mean, I think there are disparities in many different categories, right? So, I mean, you talked about the disparities with regards to infection rate. I mean, that's one of the things that was very clear, even earlier on in the pandemic, was that minorities and those from impoverished communities were certainly being infected more often and certainly dying at disproportionate rates. And so there were a couple of studies early on, particularly in New York State, that looked at sort of how this impacted things. And what we were able to confirm is just that, right? Like, you know, kids from more impoverished areas or more concentrated areas in New York City that was more reflective of lower socioeconomic status were more likely to lose a parent to COVID, and how that impacted them further economically and otherwise was just really highlighted. You know, from a mental health perspective, it is interesting, you know, there's been lots of research that has shown that, you know, depression, rates of anxiety for everyone has gone up. For adults from minority backgrounds, Blacks, Hispanics primarily, certainly it has shown that there's been increasing rates. And those studies are sort of few and far between. But what's glaringly lacking actually is the rates of psychopathology, the rates of mental health challenges for kids and adolescents from minority backgrounds. That hasn't really been studied. It's actually a gap. And, you know, prior to the pandemic, you know, we were seeing some really alarming trends, such as the increased suicide rate for Blacks that had historically been much lower than their white peers. And while it had been presumed that it was related to discrimination-based stress, which makes sense, there hadn't been any studies to really show that. There have been some recent studies to really connect the two of those as well, in terms of what we've been thinking about. But again, those things haven't been chopped up in the midst of the pandemic to be able to think through what's really happening to minority kids. This last point that I'll say is that one of the important access points for mental health, because there is like challenges with accessing mental health in these communities, but they were primarily getting school-based mental health services. And so not having those sort of detection points for trauma or having those detection points for mental health needs in the schools, these communities further suffered. So I'll end there and pass it over to Dr. Rice.
Yeah, it's an excellent answer. The reference to the loss of a parent really stands out. If you look at, you know, minority families, much higher likelihood of being a single parent family, and you know, with the death of a caregiver, then you're essentially speaking about becoming an orphan. And you know, becoming an orphan means, you know, not only the loss of your parents, but potentially transition in community, transition in school, loss of coaches or other mentor figures. And there's a cascade of, I think, you know, ACEs as you know, has been put forward in terms of the importance of series of traumas that I think comes forward from that. And you know, I think that's so important. I also think too, you know, I remember well at the height of the pandemic, what a disparity there was between those who had predominantly white collar jobs and could, you know, work safely from home, and those in, you know, the service industry who had to be out there risking exposures, and think about the children of those families. I think, we're so fortunate to have the vaccine now, but it wasn't always that way. And it was, at sometimes a major difference between those two groups. So I think, we've come a long way, but there's so much more work to be done in these areas. And sure we'll all contribute to that.
And I know you mentioned that earlier that one of the difficulties you were facing is that step down, right, back into community care. I'm just curious, to what extent were some of these other issues that you're referencing, right? I mean, obviously, in the extreme, having young people in your care who had no caregivers to go back. I don't know to what degree those were, but also, stressed out families and homes, unemployment, all those other material needs that families were also kind of left out. To what degree was that a problem for you in sort of helping step down?
Yeah, when you asked about the narrative and I shared that little vignette, it's funny, after saying that, I then realized, I had some pretty sad stories about the death of a parent. And it's funny that I kind of blocked it out because I think it's so emotional, like I don't even want to think about it, so instead I substitute one that might be a little bit more distant. There were several kids admitted to the unit that had lost a parent. And what I do remember with those kids, there was usually a sense of dissociation about the loss because it was so immediate that I don't think they had a chance to mourn just quite yet. And I think, that was a very unique thing and remains a very unique thing about COVID-19. The opportunities for mourning available to children were very disrupted in the sense that, communities weren't able to really come together to support the child with it. And that often these deaths were relatively sudden, but the schools being closed meant, less peer support, extracurricular sports being canceled means, less of an opportunity there. Faith-based communities often having services canceled. Many extended family members couldn't travel because of quarantines. There was just much less of a capability for families to really be able to process. And that's really hard. So many of those kids I said goodbye to, and I don't know exactly what happened next, and it's very sad. I think when you brought up just sort of the differences in ability to disposition based on means, that's always been an issue, but yeah, it feels even more pronounced now. One thing even this past week that stands out, there's been a real expansion of telehealth services, which I think in some ways has been a great thing. In other ways, that's been, leaves some room for improvement. But with many of the commercial insurances, the telehealth services have expanded such that you can pretty much get an appointment like next day, no matter what. And I find that, it now makes it such that if you're employed and you have private insurance, it's very easy to get you off the unit. If it's a Medicaid-based insurance, it's a little bit more challenging. But then it's a double-edged sword that I'm not certain, for all kids that the telehealth appointments are as meaningful or as productive as the in-person visits. And then I often have a little bit of a conflict about, should I let this kid wait until I can get the in-person visit, because I think it's going to be important for this kid to really establish something more permanently with an in-person visit, versus let it be what might feel a little bit more ephemeral with the telehealth, because it's a little unclear if the providers are going to be changing and things like that. So, maybe the audience has thoughts about that, or Dr. Reliford does as well too. But I think telehealth is, this whole pandemic ushered in a whole new era, I think, of virtual capabilities, and it'll be interesting to see where it develops.
Yeah. Dr. Reliford, Aaron, did you have anything you wanted to add to that though about telehealth services? Because I agree it can be a huge boom, but it also challenges as well.
Absolutely. As I mentioned, or maybe I didn't mention it fully, but even prior to the pandemic, we were doing a lot of telehealth-based work. Not exclusively, it was a percentage of what we were doing. And then during the pandemic, it really skyrocketed to the vast majority of the work that we were doing. And we were fortunate to have that platform that most of it was video-based visits and not audio visits. And I agree with Dr. Rice that there's a lot of feeling that that telehealth-based work is not as robust or not as engaging as face-to-face work. And I think that that's certainly true for some circumstances. For instance, for the younger children who for like play, and you're engaging in play, we had to do acrobatics and like use whiteboards and things like that, but it's not like being there with the kid to be able to do the play-based work that's so important, or the play supported work that supports engagement. I think also for kids with neurodevelopmental disorders, autism spectrum disorder, it makes it challenging to engage. And for some kids with psychotic symptoms or psychotic-based disorders, you really need them in the room to assess what's actually happening from a clinical perspective in terms of engagement with reality, but also for side effects, right? Things like that. But I think outside of that, generally, tele-based work can be quite effective, and to be able to provide access, particularly for those for which there's a great distance to travel, or really don't have the number of providers in the area. So I think it could be quite beneficial. One of the problems that we ran across during the pandemic was that digital divide, right? So going back to disparities, I think there were families that did not have the resources to be able to have the internet connections or the devices to be able to consistently connect to school at the very least, but certainly to mental health services. And so, when they were accessing care, it was less beneficial, because maybe it was more often to be on the phone, or maybe those individuals who were from a more impoverished background were in a household that was very crowded, couldn't get privacy really to be able to have a meaningful therapy session, or to feel free that they could sort of open up. So I think you're seeing a lot of different things. Telehealth certainly has greatly increased access, and that sort of gets to the volume that I mentioned. I think the volume increases and the decrease in no-shows that we had in our system were primarily due to access to telehealth. But on the flip side, there are these families that couldn't really be reached. So I think in the midst of this being a permanent reality in our work, I think sort of really thinking about that digital divide and making sure that we don't lose access for patients that really need it, I think that'll help to close those gaps.
Yeah. And I want to stay with you, Aaron, and to ask we had some discussions before doing this, and you brought up an important issue. So as we think, and this is for both of you, but I want to start with you, Aaron, as we think about what to expect next. So the both of you are obviously sort of describing a very serious mental health crisis, with the more severe and acute cases really sort of taking up the majority of the services that are available out there in many ways, and the attention which are always necessary. What are some of the issues that you see coming down the line that haven't been addressed? I know you mentioned, Aaron, that your concerns about the achievement gap and the impact of those issues around sort of education and young people who are sort of achieving less, and the impact of that on their self-esteem, and possibly also driving depression in the future is one concern that you have. If you can share a little bit more, what do you foresee coming forth in the future with young people, and some of the difficulties they may be facing that are kind of downstream issues related to COVID-19?
Yeah. Well, there's no way to really fully know what's going to come. But I think, like you're alluding to, there are some things that we can and we should be thinking about, right? So that, during that year where the kids were remote, they were safe, they were kept safe. And, I think people have feelings and thoughts about it overall, but there was a loss of social and academic opportunities, loss of being able to progress fully. And I think I've heard recently that sort of reading achievement certainly was lowered in the United States in that context. I think for even younger children, right, even after getting back to school, we don't often think about this, but like there's so much in terms of social emotional development that comes from sort of whole person engagement. And what is it going to be like for them to understand the social world from not being able to read the full face and to be able to understand what's going on from the perspective of another individual? I mean, what is that going to mean? I have no idea, but I think that's certainly something where there might be more behavioral challenges or more challenges engaging socially, more disconnect as a result of not really using all of those things that would ordinarily be there to sort out what's happening in a social encounter. And I think also, I personally feel it's good that the kids got back to school in person. The vaccines helped that out tremendously to provide a sense of safety for parents to feel more comfortable doing that. And it provided a platform for the institutions to sort of allow that to happen. But I think that as we get back, we'll see a little bit more in terms of what happens with regards to academic achievement, social related challenges. Where are these things going to fall with regards to that increased level of depression and anxiety? Is it going to level out because people are sort of more engaged and feeling less quietly sort of freaked out by the fact that there is a pandemic and the risk of dying or risk of getting infected, right? So I think that there are a lot of uncertainties, but I think these are things that we should really look out for.
Right. And Dr. Rice, your thoughts about what might be expecting in the future with regards to children's mental health and severity and acuity?
I think that was such a good answer. I might solely just kind of add one little element to it. I think a lot about like the missed social experiences of these years, especially for like what'll come ahead into young adulthood. I walk through Columbia's undergrad campus on the way to work when I take the subway. And it's been so sad for me just to see like what must the freshman, experience be like when so many of the kids were absent, or when you hear the stories of the high schoolers who didn't have a prom, or they didn't get to go on the the field trip to DC to learn about the government, or whatever it is that are these kind of experiences that the upperclassmen above them always did, and then they missed it. It kind of, at least from the stories I've heard, leaves them to feel as though they missed out. There's a defective kind of element of their narratives, and as a result, like I think that's going to sit with them for a little bit of time. And a couple of the patients I work with as outpatients have made the choice to sort of defer college. And at first I thought that was going to be a really tough decision, and wasn't so sure if it was with the best judgment. But then the way that it was described was like, do I really want to go to college at a time where I'm not sure what the experience would be like? And they kind of ended up selling me on the whole idea how it played out. But now I've noticed that, is it now time to reapply? And maybe it is, but I've noticed there's some stasis, and I just think it's going to take quite a lot of time to revisit this sort of gap that was created, exactly as Aaron said. And these are just some other angles to look at that.
Yeah. I'm just going to put out, briefly, if you can share, I know you're both direct practitioners. You are out there on the front lines doing this work, but I want to sort of check in and see if you could put on your possibly your policy hats for a second and just think about, if you could drive policy, what would you like to see happen in children's mental health that you think can address some of these difficulties that you faced? Maybe your 3-point plan, like what would you like to see happen in children's mental health services that you think would address some of these issues? And Tim, I'll start with you.
Yeah, I'll answer by saying just over the course of my career, I've seen so many improvements be made. When you look at the length of stay of my units, 10 years ago, it was like double what it is now. And the guy who trained me Leon Hoffman, he was unit chief back in the 80s, and he had said it was like, 6 months or something like that. I think there was like a real loss in having, the length of stay of these inpatient units be cut so short in terms of the care that's provided on the units. But the positive aspect of that is that we're really saving a lot of kids from needing to be admitted, and the care is being provided in the outpatient setting, which I think means for these children, it's not the traumatic rupture of removing them from their families. It's not the sort of pathologizing sort of aspect of like you to the child or the one who's sick, whereas like the outside world is okay. It essentially means care can be provided in a family context as an outpatient. And I think that's a really good thing. So, what I would say is like more of that, continue that trend of trying to build more resources to reduce the risk of, admissions, knowing that every time a child is admitted, it's very often a suicide attempt or some life-threatening behavior that had occurred. And I really see a lot of hope and great benefit for things like partial hospitalization programs and these intensive day treatment programs. And I think people speak with their feet. I mean, the wait lists are enormously long for these programs right now. So again, this is like just my own perspective from the area in which I work, but I can't say enough how much of a need there is for that level of care at this time.
And Aaron, your thoughts? Maybe top three wishes, if you could, to improve the children's mental health system, or at least to ensure that young people are safe and getting the services that they need.
Yeah, I think I have so many thoughts on this, so I'll try to keep it to top three. But I think that one of the largest challenges is a lack of sufficient number of providers, right? And there are many reasons for that. One of the core reasons for that is funding, right? So funding for programs that will sort of provide more community access to folks. And I think funding from another perspective is, adjusting the rates of reimbursement. So I think a lot of folks may be thinking about this, but there has historically been a big discrepancy between the reimbursement rates for psychiatric services, especially even child psychiatry services, compared to other medical specialties. And that's driven by many factors. But one of the things is that prevents a larger influx of qualified practitioners from joining the field, as well as prevents programming from being able to be more widely dispersed. So I think that funding is certainly a huge thing. I think funding also touches on sort of the kinds of programming. I mentioned community services, but earlier preventative-based services, right, are really key to preventing more challenging presentations later on. So preventative services, dyadic-based work for children who are under 5 with parents who have a significant burden of ACEs, adverse childhood experiences, to be able to prevent sort of more challenging developments from early trauma and early adverse experiences. So I would say those are my thoughts in terms of adjusting the landscape.
Thank you. All right, so we have 10 minutes left. I'd like to try to turn to get the audience questions. So please feel free to chat in. I know we've gotten some questions. Oh, we've gotten a lot of comments and questions as we've gone along. So I'll try to see what we can bring up. But of course, for those of you who haven't had a chance yet, please feel free to chat in your questions, your thoughts. So just to go in, again, I know we've covered so much ground earlier, throughout this webinar, but earlier we talked a little bit about, and some of the statistics coming out right now about higher rates of suicide attempts among girls versus boys. I wanted to know, again, from your experience, what do you attribute this disparity to? And what are you seeing?
I can speak briefly to say we know that male adolescents have higher suicide rates despite having the lower frequency of attempts, primarily because the means by which they will attempt suicide are more lethal. They'll often jump or hang, whereas female adolescents will often choose poisoning or ingestion as a route. In terms of why female adolescents have more frequent attempts, I think a lot has been written about those gendered reasons. I'm not an expert on it. I do know that sadly, there's an enormous amount of pressure on young women in the community to internalize, in the sense of men and young men are often sort of permitted to be more externalizing, in the sense of it's permitted to sort of go out into the world, and if there's problems encountered, they can kind of go aggressively tackle that problem. Whereas I think young women, they're often made to have high expectations on themselves, and when they're not able to meet their goals, they often, I think, will blame themselves, and that can often turn into a suicide attempt. That's kind of a off the cuff sort of how I would explain it, but maybe Dr. Reliford has something that would be a better answer for that.
Oh, not a better answer, just a little bit more information. The rates of depression and anxiety are higher in teenage girls compared to boys. That shift happens after puberty, and there are lots of reasons for that, some of which biological, but other reasons are the social-based pressures that are really unfortunate and different for women compared to young men.
And what kind of pressures do you see young women especially sort of being exposed to?
Well, I mean, I think, similar to what I mentioned before, those discrimination-based stresses for individuals from minority backgrounds. I mean, being a woman, being a girl in our society, and pretty much many societies in the world, it's a marginalized identity. There are lots of pressures that and challenges that women face that men don't have to, that are sanctioned by society. So, I mean, there are many things that we could talk about, but I think that's sort of the general stamp.
A question came in, kind of addresses the issue of kind of building mental health literacy. And so one question that came in has to do with, how can public health messaging encourage parents, teachers, clergy to recognize when there is a need to seek consultation with mental health providers? So addressing the issue of mental health stigma, your thoughts and what you're seeing. And it's a good question too, because it's interesting from my experience. I do see an increasing knowledge and awareness of mental health issues with, sort of high profile athletes and celebrities coming out talking about mental health issues. But I want to get your thoughts, especially again, with the young people that you're serving. I've been seeing it somewhat in young people coming in for mental health services, but also being very, very literate on mental health issues. What are you seeing? And how can we increase that mental health literacy?
Yeah. I'll dive in really quickly and say, I think that's huge, right? The more we can talk about it, and the more we can get high profile individuals speaking on it, so much better. I mean, there's stigma related to mental health. There has been, that has prevented countless number of children, adolescents, and adults from being able to access mental health services just because of the problems internally and associated with having a mental health challenge. And that's shifted. And I think that's also a reason for the increased volume as well. So when you ask, what are the things that we're going to see over time? I think with less stigma, more acceptability for mental health challenges being addressed, we're going to see more people seeking services. And so that's a general sense. But just kind of going back to minority communities, minority and immigrant communities, the stigma is much greater in those communities. And the disparities are much greater in those communities. So even more reason to ensure that we're sort of targeting those communities to make sure that there's an awareness through like religious avenues, That's a really great way to engage the communities that I mentioned.
Yeah. And you also mentioned school, which I think it sounds like it's,
Schools.
yeah, schools are a
Absolutely.
great place to do that as well.
Absolutely.
Dr. Rice, your thoughts on that question of, addressing.
Yeah, I would just add, there is a recent review, I think in the Orange Journal, the American Academy of Child and Adolescent Psychiatry, that looked at interventions to reduce suicide rates in high schools. And they found that the best evidence was for actually students' interventions directly as composed to teacher and mentor trainings. And I think that it shows that what Aaron says is so correct, that like to get the word out amongst people who are influencers for kids is so important. But there's also so much opportunity just to help educate kids directly too, that I think today's teenagers in particular are very educated consumers, like they're very familiar, I think, with social media about mental health, and they want to learn more. So I think there's a whole lot of opportunity just to do direct work and to break that stigma down through, direct work.
Well, there are a few more questions, but I am aware of time, and I want to make sure that we end on time, but also to give people an opportunity. So at the end, as you log off, please, a survey will pop up. And I know we've covered a lot of ground here today. So what we hope to hear from you folks is just feedback on it, maybe areas that we can go in deeper and sort of uncover and address on a little deeper level. So any topics that maybe this offering has kind of triggered in your minds, please send them along, complete that survey, and let us know your thoughts about what are the areas that we could provide offerings that could help you in your work moving forward. I also wanted to mention that we do have, excuse me, here we go. So as we go, so we have a couple of upcoming events very quickly. So we have a conversations with Dr. Tony Salerno featuring Jan Winhall, who's going to be talking about trauma and addiction. And then we have an offering on internal family systems therapy, an overview of best practices on March 23rd. And then we have an offering on resilience, building on the strengths of youth who have endured hardship. Kenneth Ginsberg is going to be joining us for that webinar on Wednesday, March 30th. So those are some of our upcoming events. And again, I really encourage you to complete that survey and let us know what other offerings and topics that we can address in this mental health moment, as well as any other kind of offerings that we do, general webinars and topics that we can address to meet your needs. And again, if you have if you want to access our past trainings, you can go to our CTAC website. And if you want to reach out and provide us any additional information or reach out to us directly, you can at ctac.info, nyu.edu. And again, I want to thank you all for joining us today. And I want to thank Dr. Tim Rice and Dr. Aaron Reliford for addressing this very important issue of the crisis in children's mental health. On the one hand, I am glad that we've been able to address this, but it also brings up the fact that we have a lot of work to do in improving children's mental health services. I want to thank Drs. Rice and Reliford for bringing up some of the critical issues that we need to think about in addressing these issues moving forward. And thank you all for attending today.
Thank you.
Thank you for having us.
Thank you.